The optimal diagnostic approach to vaginitis requires a strict differentiation between the three main infectious etiologies: bacterial vaginosis, trichomoniasis, and candidiasis. While office-based testing remains a cornerstone of diagnosis, clinicians must navigate its limitations. Bacterial vaginosis, or BV, is typically identified using the Amsel criteria, which looks for a vaginal pH greater than 4.5, a positive whiff test, clue cells on microscopy, and a thin, homogeneous discharge. In contrast, vulvovaginal candidiasis generally presents with a normal vaginal pH and the visualization of yeast on a prep. However, microscopy is notoriously insensitive when it comes to trichomoniasis, missing between 44 and 68% of cases. Because of this high failure rate, nucleic acid amplification testing, known as NAT, is increasingly supplanting microscopy. Modern multiplex NAT panels can test for all three common causes simultaneously, offering superior sensitivity that reduces the need for return visits. Among these etiologies, trichomoniasis requires a distinct management strategy because it is a sexually transmitted infection. Unlike with BV or yeast infections, management must always include the treatment of all sexual partners to prevent reinfection. Current guidelines recommend metronidazole 500 mg orally twice daily for 7 days, a regimen that has demonstrated higher cure rates than single-dose options. Patients should be advised to abstain from intercourse until they and their partners are asymptomatic. Furthermore, due to high rates of recurrence from either treatment failure or reinfection, a test of cure via NAT is recommended for all patients 3 weeks to 3 months after the initial treatment. This is also a critical window to screen for concurrent STIs, including HIV, gonorrhea, and chlamydia. Management shifts significantly when addressing vulvovaginal candidiasis, where the treatment hinges on classifying the infection as either uncomplicated or complicated. Uncomplicated cases in immunocompetent hosts can be effectively cleared with a single dose of oral fluconazole, 150 mg. However, complicated candidiasis, defined by severe symptoms, pregnancy, or recurrent infections occurring 3 or more times a year, demands a more aggressive approach. For recurrent cases, a 6-month maintenance regimen is often indicated. If a non-albuquin species is suspected or confirmed by culture, standard fluconazole will likely fail. In these instances, first-line therapy involves intravaginal boric acid, 600 mg daily for 2 to 3 weeks, as these species are often azole-resistant. Recurrence is also a frequent challenge in the management of bacterial vaginosis. While a standard 7-day antibiotic course is effective for an initial episode, patients with 2 or more recurrences require suppressive therapy. A common and effective regimen involves using 0.75% metronidazole gel intravaginally twice weekly for 4 to 6 months. Additionally, emerging data suggests we may need to rethink partner treatment for BV. While historically not recommended, a recent randomized trial demonstrated that in monogamous relationships, treating the male partner with oral metronidazole and topical kendamycin significantly reduced the 12-week recurrence rate in women. Finally, in postmenopausal patients, clinicians must consider atrophic vaginitis, also known as genitourinary syndrome of menopause, as a primary differential. This condition results from estrogen deficiency and causes an elevated vaginal pH greater than 4.5, which can easily lead to a misdiagnosis of bacterial vaginosis. The key is recognizing the pale, friable vaginal mucosa associated with atrophy. In these cases, the first-line treatment is not antibiotics, but low-dose vaginal estrogen therapy for 6 to 8 weeks. This approach restores the epithelium and lowers pH. Antibiotics for BV should only be considered if symptoms persist after an adequate course of estrogen therapy has confirmed a true coexisting infection.